congenital talipes equinovarus.
But you probably know it as clubfoot.
Exactly.
And it's an essential topic. I mean, it affects so many lives. Our mission here is to navigate its complex origins, the anatomy.
Understand the diagnosis, and then really zero in on the single groundbreaking non-operative treatment that just, well, it revolutionized everything.
It really did.
So the fundamental takeaway for you right out of the gate is actually pretty powerful. CTEV is the most common musculoskeletal birth defect.
About 1 in every 1,000 live births.
Wow. And it's diagnosed just by sight. And because of this thing called the Ponseti method, the huge majority of these kids, they grew up to walk, run, and be completely active.
Often without ever needing major surgery. It's incredible.
What's fascinating here is just the sheer scale of it.
Yeah, that 1 in 1,000 number, that translates to thousands of new cases every single year.
And it's not just random, is it? It seems to have patterns.
Oh, absolutely not random. We see a really strong gender bias. Males are affected about twice as often as females.
Okay, so that right there suggests it's not just about, how the baby was positioned in the womb or something mechanical.
Exactly. And the geography is even more striking. Studies show it's way more common in populations like Hawaiians and Maoris.
Which, again, points directly toward a deep genetic influence.
It has to.
Yeah.
And another thing, it's often a symmetrical problem.
Meaning both feet.
Precisely. You're looking at about 50% of cases being bilateral, so both feet are affected, which, that just doubles the challenge of correction.
Okay, let's unpack those root causes. When we see a deformity like this, is the thinking that is it purely genetic, or is there some developmental component happening in the womb?
The current understanding leans really heavily toward the genetic blueprint being flawed from the very start. We see a very strong association with the PITX1 transcription factor.
And what is that exactly?
Think of it as a crucial molecular switch. It's one of the main drivers that orchestrates how the lower limb develops in the first place.
So it's not just a muscle that's a little too short, it's a fundamental failure in the architectural instructions for the entire leg.
That's the core of it. And the family history risk, that backs this up completely. If a child has an older sibling with it, their risk jumps. I mean, sometimes up to 25%.
Wow.
And even with unaffected parents, if they have one child with clubfoot, the risk for their next child is still around 2.5%. Way higher than the general population.
It's a natural fear for parents to worry if this is just the tip of the iceberg. Is this part of some much bigger, more severe syndrome?
Thankfully, for most, the answer is no. About 80% of clubfoot cases are what we call isolated deformities. It's really just a problem of the foot's architecture.
But that other 20%.
In that other 20%, which we'd classify as a complex or syndromic, we do need to look for associated conditions. Things like arthrogryposis, which causes contractures in lots of joints, or amniotic band syndrome, myelodysplasia.
And finding those changes everything.
It changes the entire management strategy, yeah.
All right, let's get into the mechanics. To fix this thing, you have to know exactly what's out of place. And that's where this acronym CEE comes in.
KBE is the roadmap. It's the operational guide for any clinician treating clubfoot. It stands for cavus, adductus, varus, and equinus.
And that order is important, right?
It is absolutely crucial because that's the order you have to correct the deformity in.
So walk us through it. What's tight and where? Starting with cavus, the high arch.
Okay, so we start with the soft tissues, the things pulling the bones out of whack. Cavus is that really exaggerated high arch, and it's caused by the intrinsic muscles deep in the foot getting tight, along with the long flexor tendons going to the toes.
Like a bowstring being pulled too tight.
Perfect analogy. Then you have adductus and varus. Adductus is the forefoot pointing inward. It's mainly driven by a tight tibialis posterior muscle. Then varus is the whole hindfoot, the heel, tilting inward.
Okay.
And that's pulled by both the tibialis posterior and the tibialis anterior. They're just working overtime, pulling everything medially.
And last, equinus, the part everyone notices.
Right. The equinus is the rigid plantar flexion. The foot is just stuck pointing down like a ballet dancer on pointy. And that's all from the contracture of the Achilles tendon.
So when all those tissues tighten up, they literally distort the skeleton. What's the main bony problem?
The main event is this medial spin. The midfoot and forefoot basically rotate inward relative to the hindfoot.
So the whole front half of the foot is twisted.
Exactly. The talus, that main ankle bone, its neck is pointing down and in. The heel bone, the calcaneus, is pulled into varus and rotated right around the talus. And the navicular and cuboid bones are just completely displaced medially. It's like an internal dislocation that's locked in place.
So in the clinic, beyond that obvious Seiki shape, what else are you looking for?
We look for specific markers. You'll see these deep skin creases on the inside and the back of the foot where it's literally folded on itself.
Uh-huh.
But the most important subtle sign is this generalized hypoplasia, or underdevelopment, of the entire leg. The foot is smaller, the calf muscles are smaller, the tibia can even be a bit shorter. It just reminds you, this isn't a local problem, it's a developmental issue of the whole limb.
Let's shift to diagnosis. You said it's clinical, you can just see it. So why would you ever need an X-ray?
That's a great question. For a newborn, you typically don't need them. Not unless we suspect something really atypical or syndromic, but they become really important if we're, say, planning a surgery later or tracking a complex case.
So what do the X-rays actually show you that you can't see?
The key thing is that the two main hindfoot bones, the talus and calcaneus, they should diverge. They should spread apart. In a clubfoot, they look parallel. They're almost on top of each other. We measure something called the telocalcaneal angle, or kite angle. And in a clubfoot, that angle is way, way smaller than normal. And that just confirms that internal rotation.
Now, what about timing? We can see this on an ultrasound in utero.
Yeah.
Does it matter when you find it?
It matters immensely, and it's so important for counseling parents. If you see it clearly in the first trimester, you have to be on high alert for other non-musculoskeletal anomalies. It points to a much earlier, deeper developmental problem.
And what if it's found late, say, third trimester?
In the third trimester, you actually get a lot of false positives.
Really? Why?
Well, the baby's getting big, space is tight, and the foot can just be sort of crammed into a weird position.
So it's just squished.
It's squished. And it can look like a clubfoot on the ultrasound, but the bones are structurally normal. We usually just tell parents to be patient, and we confirm it clinically after the baby's born.
Okay, so diagnosis is confirmed. The modern treatment is all about the work of one person, Ignacio Ponseti. This method is the gold standard.
It is a true revolution. I mean, before Ponseti, the standard was early, massive, and often, honestly, devastating surgery. It led to stiff, painful feet later in life.
And Ponseti came along.
And introduced this gentle manipulation and casting with over a 90% success rate.
Right.
It just completely changed the prognosis. The goal is simple. Get a flat, flexible, fully functional foot.
What's the core mechanical idea he was working with?
The whole goal is to systematically and gently rotate the entire foot laterally around a stable fulcrum.
And that fulcrum is the talus bone.
The fixed talus. And you have to correct the CVE deformity in that strict sequence we talked about.
Okay, let's break it down. It starts with weekly casting. Tell us about this magic move.
The magic move is the very first step, and it's all about correcting the cavus, that high arch, and it's totally counterintuitive.
How so?
You don't try to flatten the arch. Instead, you supinate the forefoot, you turn it slightly up and in, while putting direct pressure under the first metatarsal.
Wait, the foot is already turned in. Why would you turn it inward even more?
Because that little supination move, it uses the foot's own anatomy to your advantage. It basically unlocks the stiffness in the midfoot.
I see.
By fixing that rigid arch first, you stabilize the whole structure and get it ready for the big abduction movements that have to come next. If you try to fix anything else first, the foot is still locked rigid. It doesn't work.
So once the cavus is corrected, the foot is unlocked. Then you go after the adduction and varus.
Then we use forefoot abduction. You apply slow, steady pressure to rotate the forefoot and the heel outward, always around the head of the talus.
And you just do that over and over?
Week after week, for maybe 6 to 8 casts, you're just gradually stretching all those tight medial structures.
And finally, the equinus. That tight Achilles. Always last.
Always last. After about 8 weeks, when everything else is corrected, we address the equinus. In about 80% of cases, this needs a tiny little procedure. A percutaneous tenotomy of the Achilles tendon, or TL.
Sounds simple.
It is. It's a quick snip that lets the foot dorsiflex come all the way up, and you immediately lock that position in with the final cast for 3 weeks.
You know, the casting sounds like the hard, technical part, but I'd argue the part that really defines success or failure is what comes next, the maintenance phase.
You are 100% right. The casting is just the start. The maintenance phase, using the foot abduction orthosis, or FAO, that's the psychological battleground.
A 3-year commitment, that is an enormous ask for any family.
It's huge. For the first 3 months, the child wears this brace, which is basically 2 shoes on a bar, for 23 hours a day.
23 hours.
Only on for baths. After that, it's just for nights and naps, but that has to continue for 3 full years. The brace holds the feet externally rotated, usually at about 60 degrees.
And what happens if compliance slips?
Compliance is the single biggest predictor of failure. Relapse is the most common complication. And the biggest risk factors are, well, their parents not sticking to the schedule or not getting enough education on just how critical this phase is.
The foot just goes back.
If that brace isn't worn religiously, the foot will pull right back into its old contracted position.
Before we dig more into complications, there is another way, right? The French method. It's a totally different philosophy.
It is. Ponseti is dominant for sure, but the functional French method is widely used, especially in Europe. Instead of weekly casting, it's intensive daily manipulations by a physical therapist.
And they hold the correction with tape instead of a cast.
Elastic taping and splints, yeah. The family is central. They bring the child in every day for the first few months. The technique even involves stimulating the outside of the foot, sometimes described as tickling.
Tickling.
To get the muscles on the outside, the extensors and peroneals, to fire and actively hold the correction themselves. It's about training the muscles, not just passively locking them.
It sounds gentle, but incredibly labor-intensive.
It is. Massive commitment. And while it can work well, Ponseti's consistency and efficiency make it the preferred standard for most.
Okay, back to complications. Even after a great Ponseti result, we mentioned relapse. What about this problem of dynamic supination?
Ah, yes. This is a classic long-term issue. It happens in about 30% of kids around age 3. You see them walking, and their foot just rolls onto its outside edge when they swing their leg through.
Why does that happen?
It's because of a subtle, persistent misalignment. The navicular bone never quite got perfectly seated back on the head of the talus during the casting.
And that tiny error changes the physics of the muscle.
Precisely. The tibialis anterior muscle, instead of just lifting the foot up, its line of pull shifts, and it becomes this really strong supinator, pulling the foot inward and causing that roll.
And the fix for that is the tendon transfer you mentioned.
Yes, that's the tibialis anterior transfer. We just move its attachment point a little bit laterally. It turns it from an inverter into an everter, and it balances the foot perfectly.
And the third major complication, the one you said is preventable, the rocker bottom deformity.
This is a huge warning for clinicians. This happens when you try to force the correction of the equinus, the heel, before you've fully corrected the varus and adductus.
So you're breaking the sequence.
You're breaking the sequence. The foot is so locked up that when you try to force it up, it doesn't bend at the ankle. It bends in the middle, in the midfoot. And you create this convex, rounded, rocker bottom shape. It's an iatrogenic deformity caused by rushing.
So if all these non-operative methods fail, then you're headed to the OR.
That you are. Surgery is for a residual or recurrent deformity that's just too stiff for more casting. In young infants, maybe 9 or 10 months old, we might do a soft tissue release, a posteromedial release.
And what's the big caution with that surgery?
The critical warning, learned from decades of bad outcomes, is that the extent of that release is inversely proportional to long-term function.
Meaning the more you cut.
The more scar tissue you create, the stiffer the foot becomes. Less is always more. You have to be incredibly selective.
And for older kids with bony deformities.
Then we might do bony procedures, like a medial column lengthening around age 2 or 3. For the absolute most severe rigid cases, especially with something like arthrogryposis, you might even consider a talectomy, removing the talus bone entirely, but that's pretty rare.
What about fusing the joints? Is that an option?
Fusing joints, like a triple arthrodesis, is almost never done for primary clubfoot anymore. The rigidity it creates is just. It's something we avoid at all costs, especially in a foot with any sensory issues, where that stiffness could cause ulcers down the line.
So let's tie this all together. What does this mean? What's the core lesson?
The management of CTEV is just this shining example of a paradigm shift in orthopedics.
Yeah.
From aggressive early surgery to this highly successful manipulation-based technique.
Right.
The core lesson is the mechanical logic.
Yeah.
You have to respect the CTEV anatomy. You have to correct it in that specific order, starting with that counterintuitive supination move.
Yeah.
And then success is all about the parent's dedication to that 3-year bracing commitment.
We've covered the 1 in 1,000 incidents, the genetic link to PITX1, the sequential KVE correction, and the pure mechanical brilliance of that magic move. It's a huge testament to non-operative care.
It's a profound change in the lives of millions of children.
You know, building on that genetic component, on PITX1 being a blueprint for the limb, we've seen how the mechanical structure, the foot, responds so well to this careful manipulation, but only because that manipulation honors the foot's flawed molecular blueprint. So if one gene like PITX1 is involved in something this common, It makes you consider, doesn't it? How many other prevalent conditions might have these subtle underlying molecular switches that we just haven't unlocked yet, even if we can mechanically fix the problem later? It raises this really profound question about just how deep the connection is between the structures we can see and touch and the single molecular instructions that built them in the first place.